topic, which is going to be effects of positive pressure ventilation in cardiogenic pulmonary edema. So essentially, guys, when we have positive pressure ventilation, one thing we want to know is that you will have increased interthoracic pressure. Okay, now when we have increased amount interthoracic pressure, what happens is that we want to you can imagine the chest is going to be kind of compressed, and what will that do to your preload? That will decrease your right ventricular preload, your central venous return. So your central venous return, which is going to be your internal external jugular going into your coming in with your subclavian and your jugular, making that superior vena cava, and of course inferior vena cava. Your central venous pressure is kind of be decreased. Okay, and so the right ventricle increase ITP, decrease central venous preload. Your right ventricular afterload, however, is the only thing that's increased over here, because you can imagine it's going to be pressing this on your chest, so you're going to be having pulmonary capillary compression. That overall, that will decrease your right ventricular preload, left ventricular preload massively, because you can imagine that you cannot bring air into the heart, and you can't take it out of the heart. So it's going to be really high. So there's going to be increased pulmonary vascular resistance. Automatically, you can think the left ventricular preload, it's going to be immediately decreased over there. Okay. Then we come over here to the left ventricular afterload. The positive pressure ventilation, basically, it decreases mean arterial pressure. What does that mean? Mean arterial pressure to the baroreceptors. There is going to be there's going to be baroreceptor effect, and that'll be lowering the whole adrenergic tone. So the aortic compression leads to baroreceptor reflex, and that leads to a decreased amount of the tone over there. Then we have left ventricular afterload. So now left ventricular afterload, guys, is going to be essentially you're going to be having decrease the positive pressure ventilation decreases the left ventricular mural gradient. So because the positive pressure is transmitted through the pleural, the left ventricle contracts against the smaller transmural pressure gradient, and this is going to be this is where max inspiratory efforts generate a deep negative pleural pressure. So we can see left ventricular afterload is going to decrease. So left ventricular performance is being increased. So we can have an increased amount of cardiac output. One question which I have recently came across was that when you put CPAP, there's a big problem with epistaxis. So you can get bleeding of your nose. You can imagine the pressure on your nose. Patients with nasal crusting and recurrent epistaxis are likely to relate to this use of continuous positive airway pressure. After bleeding, CPAP patients with new nasal symptoms develop dryness, obstruction, epistaxis due to the mucosa damage, and the cold, dry, pressured air and erythematous and significant amount of crusting. One question I've recently come across was that, well, how do you treat epistaxis? Well, you want to put a cotton pledge with a topical vasoconstrictor. And this the epistaxis mainly originates from the Kesselbach passage, especially and the anterior nasal septum. And nasal pinching is one of the first steps in management. And a topical vasoconstrictor can be applied if direct compression alone is not effective. The next thing is going to be insert a positive nasal pack with a catheter. That doesn't really work here. That's posterior epistaxis, more frequent older with high blood pressure, arteriosclerosis. Although uncommon in children, posterior bleeds can occur with severe nasal trauma and underlying bleeding, and should be suspected if an anterior source is not identified. Moving on over here, guys, endotracheal tube. If it's going to be advanced too much, it can go into your right main stem bronchus, so that can be quite problematic. It can cause asymmetric chest expansion. So on one side you may have higher, other one you're going to have low. An ideal position is like 2 to 6 centimeters below the carina. We're going to be speaking about carina in a moment. Before that, I want to speak about what's the initial extubation criteria. So you guys recall the extubation criteria is going to be 3 key things, okay? One is going to be a pH 7.24, okay, more than 7.24. A PaO is going to be 60, and the FiO2 is going to be for about 40%. And we're going to have the respiratory efforts. So you can see the body's kind of, everything is getting back. We had a case over here. The patient has a pH 7.35, PaO2 94, COO2 45, FiO2 60%, PEEP is 5, Title 136. What's the next best step over here? You want to decrease FiO2. FiO2 is in the air. It's in 60%. That's really high. and you want to keep a low spontaneous breathing trial. Once the patient demonstrates enough effort, so that means his pH is above 7.5, which is in this case, and minimal FiO2, low PEEP2, low, then we can go for spontaneous breathing trial. So we're going to do those really important dynamics of ventilation, especially during cardiac edema. Hope you found this really useful, and hope to see you guys next time.